Good afternoon, everyone, and welcome to the next installment of the Porzio Planning webinar series. We are so excited today to be talking to you about memory issues and aging, medical and legal perspectives. I'm joined today by Dr. Matthew Barnas, who is a geriatric psychiatrist, and believe it or not, he will actually explain to you what it is that means. And just to remind you, this webinar is part of a service of outreach that Porzio Planning has for the community. Really, the purpose of it is to connect you with the people that we work with mutually on clients, the people that we go to for advice when we need advice in specific areas, and honestly, the people that we enjoy talking to. So the conversation that you hear today isn't going to be very different than a conversation that Matt and I might have as we're discussing issues related to a client, or just sitting down over drinks when we used to actually be able to sit down and do that and just talk about what's going on in our practices for what we're doing. So the purpose of, that we have these webinars is our goal is to empower you to be able to make better decisions. There are so many things that happen in life that you don't have any control over. But one of the great things about law is that there are many actions that you can take to put yourself in a position of control through advanced planning when it comes to things. And nothing, I think, is more central to that theme than the idea of memory issues when it comes to aging. So just a little bit more about myself. I'm a principal in the wealth preservation team at Porzio, Bromberg & Newman. We focus within the wealth preservation team on estate planning, elder law planning, tax issues, working with owners of closely held businesses. As I said, it is my great privilege to have Dr. Matthew Barnas joining us today. Matt, can you just give folks a little bit more about your background?
Sure. Hi, Deirdre. How you doing? I am a geriatric psychiatrist, so that means I completed university studies, Bachelor of Science, and then medical school, Rutgers, New Jersey Medical School in Newark, and I completed adult psychiatry residency training also at Rutgers in Newark, and then I specialized in geriatric psychiatry at Yale in New Haven. Not many geriatric psychiatrists, and so there's also, as you noted, there's not a lot of awareness of what exactly is it that we do. So geriatric psychiatry relates to helping elders and working with elders, and we address the typical things that psychiatry would address, such as mood issues, depression, anxiety, sleep issues, insomnia, perhaps something like schizophrenia or bipolar disorder as it advances into later life for an older individual. Maybe they've had it all their life. But, the other area that is unique to geriatric psychiatry is cognitive disorders and dementias, and especially Alzheimer's disorder, as well as the rest of the dementias. So a geriatric psychiatrist, as it pertains to Alzheimer's disease, overlaps with a neurologist, and they're kind of redundant on that note. So a geriatric psychiatrist has similar training and skill set in evaluating and treating dementia as a neurologist would have. That would not be the case for other neurological issues, like if a patient has multiple sclerosis or Parkinson's disease or any other type of neurological issue. The illness itself wouldn't necessarily fall under the care of a geriatric psychiatrist, but when it comes to dementia and cognitive disorders, we have that training and expertise, and so we are a first-line provider for those conditions in the same way that a neurologist would be.
I appreciate that. So one of the things that I just want to pick up on, I know you're going to talk about that. You did not say dementia, you said dementias. And this is one of the things, so Matt and I, we've worked together on a number of clients, but I actually had the privilege of seeing him speak live and in person about 3 years ago. And even though I've worked with seniors with families that are dealing with aging issues for a number of years, hearing the medical perspective of, what the body goes through, where the behavioral issues are coming from. I've actually parroted that with my clients many times over the years. And I think it offers a sense of comfort, because Alzheimer's dementia, slowing down, your loved one wears the same face, but they're not necessarily the same person. So to be mad at the disease versus being mad at the person, I'm hoping that, by the end of this, you'll have a better understanding of what Matt means when he talks about it as a disease, what kinds of strides that people are making in attempting to deal with those, what kind of treatments are available. And then I'll just go into some of the legal issues that you can think about, again, because we're looking at planning. Before we go forward, as always, this is for you. Matt and I've had these conversations many times. What questions do you have? Please ask them in the chat box or in the Q&A box, and we'll try to weave them in. If we aren't able to weave them in, we'll try to address them afterwards. But if anything here, touches on you, this is the time to ask. And then just one more thing, for your friends and family, the reason I asked Matt if he could join me in December is this is traditionally when people see family members maybe for the first time in a long time. And oftentimes it's when you see that dramatic change because you haven't been with them every single day and you see that they're slowing down or they're acting oddly or they're not dressing or whatever. And Matt will go into all of that. So hopefully this will give you sort of a game plan to look at as you are enjoying your holidays with your family as much as you can to maybe see if there are some issues that you want to be proactive about. So with that, Matt, can you sort of, if we can flip to the next slide here, you told us what a geriatric psychiatrist is, which again, I didn't actually know that there was one. I don't believe until somebody introduced me to you to begin with. But you started, with the idea of dementia. Can you talk to us more about, what that means from a medical perspective versus the layman's terms that the rest of us throw around?
Sure. So dementia is kind of an umbrella term. There are multiple different types and causes of dementia. Alzheimer's is the most common one, so that's why it's often considered synonymous with the word dementia, but there are other types of dementia as well. And what we're talking about is impairment in cognition being memory, language ability, executive function ability, attention and concentration. So impairment in different domains of cognition that are produced by brain dysfunction, which we'll look at some pictures actually, like you mentioned, to really see what's the effects of this kind of change. And it leads to impaired functioning. So in other words, changes in the brain, unfortunately, lead to changes in a person's ability to do the things they used to do. Maybe manage their medications or manage the checkbook or go shopping safely with the car, drive to the store, follow the shopping list, pay, get the correct amount of change, drive back home safely. Unfortunately, as dementia advances, a person is not able to do all of those kind of things that they used to do.
Excellent. So one of the things that I think here, just I want to touch to from a legal perspective, is we get calls from people saying a guardianship issue, and it might be it's a guardianship issue because my father has a new girlfriend and we're afraid that she's taking all of his money, right? I think the key thing that people have to understand with guardianship in New Jersey, and this is why we work so closely together, is that in order for a guardianship to be instituted, a person has to be impaired. And we'll go through this in a little bit more detail, but you need the assessment, not that dad's making decisions that you don't like, but Matt, with what you just spoke to, that dad, because of physical issues, no longer has the ability to make those executive decisions in the same way. It's a very important thing when we're looking at how do we engage in substituted decision making, as we work together. And the fact that somebody's making choices that you don't like, or the fact that you don't understand their choices, if they are not impaired, adults in New Jersey are free to make bad choices. People make them all the time. So I just wanted to touch on that, sort of weave in some of the legal questions.
Right. So there has to be a medical basis, like a medical issue impairing their judgment. And that's where a geriatric psychiatrist can help to assess and see, is there something going on in the picture, like some form of dementia, which is in turn interfering with their decision-making ability.
Excellent. So I know at the end we're going to go through sort of the assessment process. So I didn't know if you wanted to go to the next slide. I'm sure I'll have more questions.
Yep, so I have a little bit of the epidemiology here, and if you're wondering what epidemiology is, epidemiology is a branch of science that just looks at the distribution patterns of a condition and also looks at what are some of either the causes or risk factors. So when we see epidemiology, it's such that Can you go back one slide? So that's where we're saying it's, for example, 5 to 10% of the population over 65, but 25 to 40% of the population over 85. And it helps to point out age is a risk factor for Alzheimer's disease and for all dementias, actually. And you can see here in the numbers, in a younger age bracket, it's less of the percentage of the population. In an older age bracket, it's a higher percentage. I mentioned Alzheimer's specifically is somewhat synonymous with the word dementia, at least among the lay people, non-medical people, for good reason, because it's really by far the most common type of dementia. So most of the time when people are talking about dementia, they're usually talking about Alzheimer's, since it's the most common one. It's also considered potentially a future public health crisis, because the population of the world is aging and the cases are anticipated to increase and increase, unless, of course, hopefully, you know, fingers crossed, science can come up with an effective treatment to either to slow down the illness or cure it altogether, which would be wonderful. And I am optimistic about it. You know, not to stray off course, but just look at how science was able to come together on a vaccine from multiple different laboratories for the current coronavirus. So I'm optimistic. There's a lot of smart people working very hard on this, and that something is going to change in terms of treatment for Alzheimer's in the near future.
So I want to just talk to 2 points before we move on. So one is, you say that you consider this to be a future public health crisis. I have to say that for the families that I work with, it's sort of, I'm going to say, it's sort of like the future is here. And I want to emphasize, Matt, something that you said. If you've attended previous webinars that we've offered, one of the things that we emphasize is the aging statistics of the United States. Within the next 20 years, north of 20% of the population is going to be over the age of 65, and north of 11% of the population is going to be over the age of 85. One of the I'm just going to use the word consequences in a non-judgmental sense of the great healthcare advances that we've really made over the past generations is that people are living longer and longer and longer. So, you know, Matt, I think that you would agree. It's not that Alzheimer's is necessarily a new thing, because I sort of feel like it is. I sort of feel that, you know, did our parents' generation really deal with this as much as we deal with it now? But it's also that people are getting older, and if part of the epidemiology is age, we have more people that are falling into those age groups right now. You know, so that's one thing. When looking at treatment, and you don't have to do it now because I know you have some other points to talk to, I would love, though, if you could just reserve a couple of minutes, or we can get to it at the end. You know, what might treatment options look like, you know, in terms of, to your point, you said slowing down the disease, not necessarily eradicating it. So I'm just going to make a point there that we can circle back at that at the end, okay?
Sure.
Excellent. Do you want to move to the next slide then?
So we mentioned epidemiology also looks at risk factors. So these are factors specifically for Alzheimer's dementia. The thing about risk factors, a person can have many risk factors for an illness and never develop that illness. And some people don't seem to have any risk factors for an illness, and yet they do develop it. So it can be a little bit vexing, but in general, risk factors do correlate with later on developing the illness. So increasing age is the biggest risk factor for Alzheimer's dementia. Some others would be cerebrovascular disease, what we call metabolic issues like high blood pressure, diabetes, elevated cholesterol. Dyslipidemia has to do with cholesterol levels. A history of a head injury. If there's a family history, genetic factors such as the ApoE4 allele is like a genetic risk factor. Some other types of health issues like Down syndrome are associated with an increased risk for Alzheimer's. Alcohol abuse, and also possibly depression. I just want to make one quick point about the family history in terms of its relation to Alzheimer's. It's a very common question that I get in my practice is, you know, it's in my family tree, or my mother or one of my grandparents has has Alzheimer's, does that mean I'm destined to get it? And the answer is thankfully no, absolutely not. You're not destined to get it. In the types of family tree that we're talking about here in America, in our population, it's only a very small increase in risk. If you have family members with that condition, you only have a small increase in risk of having it. There are rare kind of types of Alzheimer's with certain types of cause, a genetic predisposition. For example, in Colombia, in South America, and also among the Ashkenazi Jewish population, where they have some of those individuals are in a family tree with a certain specific type of genetic issue that most of the family tree develops Alzheimer's, but that's very rare. So for our audience, if you have someone in the family who has Alzheimer's dementia, what's the impact on your personal risk? It's a very small effect. It's not a large effect.
So two questions that just came to mind for me. So one is, say age is the greatest risk factor. Having said that, I've experienced families that have clients with early onset Alzheimer's, some of which 40s and 50s. So this is not 65, 85, types of situations. Are the treatments for that different? Is it different with early onset Alzheimer's, or is the name such simply because of the age group that we're looking at?
So early onset Alzheimer's, thankfully, number one, it's not that common. It happens, and we do see it just as you've seen clients with it, but it's not that common, thankfully. And what can be different about it maybe can be some of the presenting symptoms. So normal typical presenting symptoms would be, for example, forgetfulness, for a typical case of Alzheimer's. Maybe for early onset, a typical symptom would be like language changes early on, or a different type of a presentation. Always the classical memory loss, dense memory loss that occurs in a more traditional case of Alzheimer's. The treatment and management is similar. It's just that it's unfortunate because it's challenging because the person is so young. And that has implications. Maybe they still have young children. They're still working. They have a career and an education. So some of the impacts are even more difficult and harder and worse for the early onset cases.
So one of the other things that you mentioned, some of the factors said blood pressure, cholesterol, diabetes. This is something that has been seen as a public health crisis, particularly in the United States, right? In terms of what it is. So, and this is just for my own edification, but is it because you have that condition? If you have treatment for that condition, does that have any relationship to dementia, Alzheimer's going forward? Is it more of an untreated condition? So as an example, somebody's concerned about Alzheimer's, is taking care of their blood pressure, their cholesterol, their diabetes, keeping it under control, a way of reducing their risk factors? And I know that's not a black and white, but it's just a point of curiosity from a health perspective. Yes,
absolutely. It's so what you're touching on is like healthy lifestyle and good personal health. So if a person is taking care of their health as best as they can, and for example, working with their doctor to keep their blood pressure in a healthy range, to manage their diabetes, or hopefully avoid it altogether, to keep their cholesterol level in the right healthy range, that does lower their risk of Alzheimer's. Yep.
So maybe for some people in our audience, because sometimes some of you have, how do I call this? Parents who are difficult patients, to get them to go and see the doctor. Maybe if the fear of Alzheimer's might be able to get them to take their blood pressure medication. So just an idea. So Matt, if you want to continue your presentation, that'd be great.
Sure, we can move to the next slide. So if you were to see the doctor and presented your loved one perhaps and were memory issues, what would be one of the first things that the doctor would do would be some blood work. So I just have listed here, almost everything on this slide is a blood test, with the exception of the urinalysis. UA is a urinalysis. And what we're looking for is there something medical here that really contributing to the symptoms? Could it be a different medical issue causing the person to be forgetful or confused, and maybe it's not Alzheimer's? So, so we would check some different tests on the blood work and make sure that that all looks okay, including, for example, thyroid studies, including a CBC, which shows your white count and helps to make sure that the person does not have an infection. BUN and creatinine would be kidney function, for example, and making sure their kidneys are working okay, liver is working okay. B12 and folate are vitamin levels, and sometimes if you have certain vitamin deficiencies, that can cause cognitive and other types of manifestations. So that would be one of the first things. These days, and especially, you know, in the New Jersey, New York, tri-state area, we're lucky that we have really excellent medical care and legal care, you know, legal counsel available as well. There's a lot of excellent professionals in our area. So in our area, a lot of times the primary doctor may already have looked at all of this, was my point. But if not, this would be, for example, some of the things that I would be looking at.
Yeah,
We
so
can
one
go
of
to the
the,
next.
yeah, just as an aside, you know, one of the things that I've seen families, and I'm sure that you've seen this, is if people have urinary tract infections, that those can, you know, certainly present, you know, different mental states. So, you know, I think that the takeaway here is, instead of starting with knowing what the problem is, and sometimes families may think that that's the case, is you really need to go and get the medical assessment done to identify the problem that you're talking about, because what we as lay people may commonly think of as, well, these are definitely the signs of dementia. This, from what I'm understanding you to say, there could be a wide variety of other things that might even be treatable that would then be able to address that. So
yes, very much so. And just quickly, that you're absolutely right. And sometimes family members are looking at me like I'm crazy when I'm telling them we have to check mom's urine or dad's urine, and they're saying, well, but many times there might be a urinary tract infection, and when you're younger, you may not even know you have a urinary tract infection, but as you age, it can really cause other issues, including a lot of confusion and sometimes even hallucinations and that type of thing, but could just be confusion and forgetfulness, what we would call an altered mental status. And it could be something as mundane as a UTI that could be very treatable with the proper antibiotics.
yeah, so again, you know, so as a takeaway for our audience here, going and getting the medical treatment instead of, how do I put this, going to Dr. Google to analyze what your aunt's situation is, is something that would be worthwhile to do. So that's great. If you want to go to your next slide.
Some additional tests that sometimes might be done, might not be done, depending. In our area, for example, in New Jersey, Connecticut, right, Lyme. On a personal note, my wife just had Lyme disease this year and was on antibiotics for it. Thankfully, they identified it early, and she did not have any cognitive symptoms. But for example, Lyme disease for some people can cause a lot of cognitive symptoms. So things like checking for Lyme, checking an EKG to make sure a person's heart is functioning properly. A chest x-ray, that's another one, is that sometimes a person might have a lung infection, a pneumonia or something like that. And that can also result in an altered mental status, and they present with confusion. Not as often, but sometimes we'll check a lumbar puncture. In layman's terms, that's a spinal tap. That would be a neurologist doing that. Heavy metal screening also, we don't really generally do that all the time, but that would be like, depending on what industry and career a person had, they might have been exposed to certain toxins and toxicities. And so sometimes it could be possible they could have like a type of a metal poisoning, like lead or other type of metal. It's not that common, but it could be something that a doctor might look at as well.
All right, so the first thing it sounds like is to rule out everything. You know, I was going to ask you this later, but just the services, because you're providing medical services for those of us who are over 65, this is all going to be covered by Medicare in terms of trying to figure out what these issues are. Is that a fair statement in terms of the medical piece of this?
Very much, very much so. Yes, under their Medicare plan, correct, under their
Excellent.
coverage.
So therefore, your parents have no reason not to go and get a checkup to see everything that's going on. So if you want to move forward, that's great. I just want to make that point.
So another possibility in terms of the workup could be what neuroimaging, or like a brain scan. And it was determined that, you know, Medicare will cover, and it's appropriate, a CAT scan or an MRI. It is not used for diagnosis. So a CAT scan or an MRI does not diagnose the condition. However, in terms of what Deirdre just wisely mentioned about rule out, it may help us to rule out that there's not something else going on there, maybe a tumor, maybe a different type of condition, maybe what they call a subdural hematoma, like a collection of blood under their skull, maybe if they bumped their head. So a CAT scan or an MRI is another approach, just to make sure we're not missing something medical, something else could be going on there. I point this out because sometimes people misunderstand that a dementia diagnosis is made on the basis of a brain scan, but it's not.
Excellent. Thank you.
We could go to the next slide. So just what we were talking about earlier in terms of how an individual looks from the outside versus what might be going on the inside can be very different. So when it comes to Alzheimer's, many times the individual still looks the same. Sadly, in many cases, they're very healthy. So their exterior and their body and their physical health looks great, and they look like the same person they always were. However, what's happening on their inside and with their brain health it's a different story. So in this image on the left, it's what a healthy brain looks like. The top part, cortex, and then down below, you can see on the bottom left, there's a black line going over to the word hippocampus towards the bottom. And on the left half, you can see the hippocampus is very full and dense. On the right, that's an example of an advanced Alzheimer's brain. You can see how the cortex has a lot of atrophy, shrinkage. And that's all, you know, it should be full, like on the left. And then specifically, you see the line going pointing to the hippocampus. You can see it's just totally empty. The hippocampus is the memory center of the brain. So seeing that change on the left where the hippocampus is full and dense, and on the right where the hippocampus is basically an empty area, that physically is showing you on the brain tissue why the person's memory is not functioning the way it used to function.
So Matt, I have to say, I find this such a stark image of, you know, exactly what it is that this disease does. And, you know, while I do try to be upbeat, you know, when we're talking about this, that, you know, just the visual of the loss of memory is just so devastating. I actually asked Matt to include this picture in the presentation because it was in the presentation that I had watched him do a few years ago. I use this example, you know, when I'm talking to families who are so beyond frustrated with, you know, mom's behavior, dad's behavior, uncle's behavior, because I think that they're looking at the person sometimes, and it's getting to the point of objectivity. So if any of you are caregiving, you may want to keep this in mind, that there has been a physical change, even though you can't see what that physical change is. And because you're not going to know exactly when that's going to happen. And to Matt's point, you know, if I'm looking at this brain here, if I understand what you're saying, the person doesn't have to have any physical conditions that this is then causing. So their life expectancy is not necessarily, you know, it's not like you've got lung cancer or something along those lines. You know, I've had clients that have had advanced Alzheimer's, have been, you know, institutionalized for north of 10 years. Now, not many, but there has been that situation because I've had very healthy individuals with very advanced, you know, having their brains look out, unfortunately, very much like this. You know, so hopefully for those of you who are caregiving, this might be a stark image you can take with you of how the person has changed on the inside. So maybe you can be a little bit more upset at the disease than the person. So that's just my human 101, from counseling families who are dealing with this issue.
Absolutely. I also see that in my practice, is that unfortunately, due to the individual can have many different behavioral issues, or inability to do simple things that they used to do. And family members can misinterpret that as the individual's being stubborn, the individual's purposely not cooperating, et cetera, et cetera. So I agree, and I do try to do a lot of education with family members on this note as well.
Excellent, thank you. And I know you've got more pictures for us coming up, so.
Yep, we have another one right here. So these are examples of a PET scan. A PET scan is a different type of an imaging process that actually metabolic activity in the brain. So the more colorful and the more bright is better, and that's showing that there's a lot of activity in the brain, and that's why the normal image on the left is the most colorful. And those dark images in the two kind of in the middle there on the normal one, those are the ventricles. So those are expected to be dark like that. Then in the middle, we have what's called mild cognitive impairment. That is like an in-between or like a precursor stage to Alzheimer's. And you can see that those darker images are growing, and the bright red, very active areas of the brain are lessened. And then finally on the right, on the Alzheimer's brain, you can see that there's just a very large area of inactivity. So that big dark area and the dark colors suggest lack of activity. And so this is where we can actually show the brain is just not functioning. It's shutting down, and this is why the brain is not able to do the things it used to do when it was healthy and younger.
You mentioned, and also if other people have questions, please make sure to continue to add them to the chat box. These are the questions that are coming to my mind. You had mentioned earlier that I guess a neurologist would be doing these scans not for diagnosis, but to be not necessarily for treatment, but because it's part of the diagnosis that you're looking at. Is it difficult for somebody then who's potentially having these behavioral issues? Like, what do these scans entail? Do you go to your primary care doctor, who then refers you to a neurologist, who then just if people are curious,
Sure.
How does it work?
Sure. So yes. So if it's determined or decided that scans make sense, any of those doctors can order it. So some primary care doctors are very active with this type of workup and issue. So even the primary care doctor may order a CAT scan or an MRI. The same thing, obviously, definitely a neurologist would be able to order it. And likewise, I also order them in my practice as well. So any of those doctors are able to and do order those kind of scans. This particular type of scan, the PET scan, it's more so considered like a research tool, and it's not a typical frequently used scan for Alzheimer's, but this was more so just to show the audience what it entails and what it looks like, and the disease progression. But also, PET scans may become more common as we go forward and by Medicare. In general, Medicare wouldn't cover a PET scan. There are some circumstances that it does.
Okay, excellent, thank you.
We could go to the next slide. So we mentioned earlier that there could be different types of dementias, not just Alzheimer's. So I have there listed conditions associated with dementia. AD is Alzheimer's. VA, that's vascular. So vascular dementia would be the most common one would be a person has a stroke, and after the stroke, they're not the same, and they have cognitive and functional deficits after the stroke. That would be considered, they could have vascular dementia, depending on how badly their cognition is impaired. Strokes are interesting in that it depends on where they occur, where in the brain, literally where, and then how big and how bad they are. Some people have a stroke and just make a full recovery, and other people can have a stroke and have like permanent disabilities ranging from physical disability and walking problems to both walking and memory and mental problems. So it depends, but vascular dementia is typically related to a stroke. There are some other types of vascular dementia, but that's the common one. Dementia with Lewy bodies, DLB, it's similar to Parkinson's. It's a related condition to Parkinson's, and those people also have a tendency to have visual hallucinations. Frontotemporal dementia is a very different type of dementia in that it can occur, it tends to occur in younger folks, younger patients. It has a lot of language and communication changes and speech and reading and language changes. Occasionally there's a subtype that has a lot of behavioral changes. That's the presenting symptom. And those patients do come to a psychiatrist because it almost looks like a bipolar disorder or a mental illness, like a traditional mental illness, but it's a form of frontotemporal dementia. CJD is Creutzfeldt-Jakob, so that would be like, it's like a prion disease. A prion is like, it's not exactly a bacteria or a virus, but it's something like that that's transmissible and that can cause a dementia. It's unique because it's fast progressing. Similar to what you may have heard over the years in the news, like mad cow disease. So mad cow disease is you eat contaminated beef, it has the prion, and then you get a fast progressing dementia. So Creutzfeldt-Jakob is similar to that. Parkinson's disease, thankfully Parkinson's disease, they don't start to have dementia until many, many years of the illness. If you're familiar with Michael J. Fox, you can remember he had onset of Parkinson's many years ago, and he has stayed in the public eye, and he had continued acting and so forth. Lastly, I've noted there, HD is Huntington's disease. So that's just another neurological condition that can sometimes result in the dementia. What we look for and hope to find are the conditions listed below, are areas maybe where we may have an effective treatment that might be able to reverse the situation. So when we're doing a workup, we're hoping to find one of these reversible causes, which includes thyroid issues, a condition called hydrocephalus, maybe a vitamin like B12 deficiency, maybe a different psychiatric issue like depression, which is treatable, could be a substance intoxication or a withdrawal, or a medication side effect. You know, we mentioned a urinary infection could cause some mental status changes. Sometimes a person is introduced on a new medication, and the medication might cause psychiatric or mental or cognitive disturbance. So we're also looking at, are there any new medications? Is there something with the meds here that could be contributing?
So I want to touch on sort of the depression thing. And again, not a medical doctor. I got to go, I thought I went to school for a long time, but I went a lot less years than you did, okay? Oftentimes I say to my clients, you know, two people who potentially need assistance, if they're living together, they can live independently. But then the issue that you run into is that one partner, one spouse passes away, and the other spouse, it appears to the family sometimes very suddenly, like they were perfectly independent and now they're not. Can you touch more on the depression issue? Because, you know, when you're, you know, look, you've been married to somebody for 45, 55 years, whatever the case may be. And I don't think people really think about the fact that mom or dad could be depressed, and it's not something, you know, it's not the Alzheimer's, it's not the pictures that you had showed us, you know, and how speaking to somebody like you when they're seeing those issues, you know, might be able to allow them to move into a course of treatment that would assist with, you know, we expect to be depressed, but when you're older and now you seem different, I don't think people think of depression as something that could be the cause. I think people jump straight to dementia, Alzheimer's, you know, and all of these other things.
Could we skip ahead 2 slides? So depression is unfortunately also a very common thing as we get older. And one of the themes is loss, that we're losing our health, we're losing some of our independence, maybe we're not driving anymore. And we're losing loved ones. And to your point, sometimes we lose our spouse. And yeah, so depression can be very, very common in the elderly. And it can present a little bit differently. As you may know, there's like a generational stigma for some of the older folks that the word depression is a loaded word, and they want to say, I'm not depressed. So generally, when I'm probing for those kind of concepts, maybe I'll use words like, have you been feeling a little blue? Have you been feeling a little down in the dumps? And those are kind of, code words for depression, but maybe don't elicit the same kind of reactivity and negativity that the word depression might. Some clues that a person might be suffering from depression from dementia, that's what's laid out on this slide. With depression, a lot of times the time course and the onset is more discrete and identifiable. So to your point, maybe the family notices, yeah, dad has been really different ever since mom died, and mentally he declined a lot. Well, Alzheimer's doesn't progress that way. So that suggests that maybe it's a depression. And then there are some other distinguishing characteristics that a doctor would be aware of. We don't have to get into all of those right now, but the point is that yes, depression is in among what we have to be thinking about when someone's having mental status and memory and cognitive changes. And sometimes the life experiences that are part of that phase of life as we're getting older can tend to causing depression, and it's something we have to be aware of.
And you had it under the thing, your heading there was that it was reversible. So again, for our audience's perspective, in meeting, with a professional such as yourself, there may actually, this is now potentially an opportunity for improvement, as opposed to something like Alzheimer's, which unfortunately right now only moves in one direction.
Very much so. So for depression, we have a number of different types of treatment approaches that are all robustly helpful, and we can help people with depression improve and get back towards their normal self and baseline, whereas we don't really have those types of robust treatments targeting Alzheimer's, at least not yet. So if we can identify that the case is depression as opposed to Alzheimer's or a different type of dementia, there's upside to that because we can treat the depression, and there's a good chance we can really help this person get better and get back to them being themselves again.
That's excellent. Did you have other points? Because other than that, I did want to talk some about sort of, the practicalities of the assessment process and things like that, but I definitely want to give you an opportunity to complete what you'd like to share with the audience.
Just if we go back one slide, just the last thing I would say is we just want to be aware of normal aging, because in the same way I get patients who worry and fret about the family tree and there's some Alzheimer's and am I going to get it, and I have to reassure them you don't have a big risk. The other thing is just be aware there are changes that are normal aging that are normal, and it does not mean you have Alzheimer's, and that would be not as quick as you used to be mentally figuring things out. A perfect example, maybe your grandchild is 2-3 years old, they have the iPhone in their hand, they can figure it out and they've mastered it. You get the iPhone in your hand, you can't figure out what the heck to do with the iPhone. So that kind of a thing is normal. A little bit of forgetfulness, but then if you get the clue or the hint or later it comes back to you, that's normal. And basically the final point on normal versus abnormal, when it's normal, the changes that you're noting, they're a little bit annoying, but they're not disabling.
Okay, that's fair enough. And I guess we do have to remember that, not everything is going to be a medical disease. Can you do me a favor? Can you flip over to the end of Dr. Barnas's slides? Oh, wait, before we go, pause on this one. So Matt, can you quickly go through the sort of Alzheimer's top 10 symptoms again? So, and here's what I say to the audience, as you are listening to this, if somebody comes to mind, this is someone who should be speaking to a medical professional. That's why we're doing this. So if you just want to quickly go through these.
Sure. So the most common symptom and the hallmark symptom is memory loss. So forgetting things they used to know, poor recall, that kind of thing. Difficulty performing familiar tasks, things they used to be able to do. Maybe, cooking at the stove, or using the remote control for the TV. Problems with language, they can't get the word out, they're searching for the word, they talk around what they're trying to say because they can't get the word out. Disorientation to time and place, difficulty with time relationships, getting lost in familiar neighborhoods. Change in judgment, so this is where a lot of times Deirdre and my practice intersects, is if the person's having decision making or judgment problems. Maybe they get careless with money, socially inappropriate behaviors, dressing inappropriately, like on a warm day wearing several layers of clothes outside, that kind of thing. Difficulties with abstract thinking, they can't problem solve or maybe balance the checkbook, where they obviously used to be able to do that. Misplacing things, either losing them or putting them in strange places. The iron in the freezer, or the wristwatch in the sugar bowl. Mood changes or behavior changes for no apparent reason. Personality changes. And then the last one, this is actually also a very common symptom, and this one is very stressful for the family and less so for the patient: apathy. So they can be very passive, very disinterested, sleeping, just want to hang out on the couch all day and watch. I used to call it Law and Order reruns, but now these days I think it's like NCIS reruns. So they just want to hang out and watch NCIS all day, every day. And meanwhile, their significant other wants to go see the grandkids, go food shopping, go for tea with their friends, or lunch, in the pre-coronavirus days. But the patient is just disinterested and just pleasantly happy to sit on the couch all day. So apathy is one that's really difficult for the family, and the patient is okay with it.
So, I mean, there are a lot of NCIS reruns, I guess, that you could say. So, excellent. If you want to just move to the next slide, please. So what I want to talk about next is just the mechanics of assessment, okay? So again, because we're working with families that have aging loved ones, and we're looking at it from our perspective, from the financial and legal side, which is to say, what type of care might somebody need? Can we assign a cost to that care? What do they have in assets, and how can we develop a plan for them to be able to address that? We cannot opine as to the care. So one of the things that we might do is refer the family over to Dr. Barnas's office to be able to do an assessment, because that then informs going forward what care might be needed by somebody. So Matt, if somebody's contacting your office, coming to your office, what should they anticipate from an assessment perspective? Because you have spent a lot of time here talking about all the things that you do to rule to see if there's any other cause of the issue other than dementia or Alzheimer's.
Right. So we already went over. We would just want to make sure medically everything's okay, and that was just as straightforward as the correct blood work, maybe plus or minus a brain scan and a urinalysis. And then upon review of all that, it's really the family providing history of that change and that decline from they used to be able to do this, and their ability and functionality is declining and changing in a bad direction. And then we would do meet with the patient and do some cognitive testing to see how they perform on the cognitive testing. A lot of the time, most of the time, the testing that we do is sufficient to elicit the deficits and the shortcomings and the symptoms. At times, we want to send them for even more detailed testing. That's like a psychologist, a type of a psychologist called a neuropsychologist. Shorthand term is neuropsych testing, and it's basically pen and paper and interview testing, but a few hours worth. So sometimes that's doable and the person can get through that and participate in it. Sometimes it's not, depending on the individual. A lot of times it doesn't come to that, but that's also an option in the mix. So it would be reviewing the medical stuff, reviewing history and facts and details from the family, and then meeting the individual and interviewing them and doing some structured testing with them.
Okay. So we had a question from the audience as to sort of how do you do an assessment? So if you need further details, let us know. But I think that that's a great answer for what it is that it looks like. And then, if I, again, having worked with you, you issue basically a report, I'm going to call it, for the benefit of the family. Just let's say it is a dementia diagnosis. What kind of treatment plans are out there? Because it's not, I don't believe that you tell people that, okay, great, you have dementia, there's absolutely nothing you can do. Presumably there are other things. And just in broad strokes, so, if a family, because oftentimes it's difficult to get the loved one to the doctor. So if they're going to get the loved one to the doctor, what is it that, once they have an understanding of what it is that they're dealing with, what might a treatment plan look like?
So there are some treatments and medications available for the cognitive piece. Broadly speaking, Aricept, Namenda, Exelon, those might be some names that people might be familiar with. They do help a little bit, modestly, not robustly. Many times to the naked eye, the family members say, it looks like it's not doing anything to help, but they're helping a little bit. The other place where we can help a lot is, we haven't touched on it, another whole constellation of symptoms that can come from dementia are what we call the behavioral symptoms. So there can be insomnia, reversed sleep cycle, sleeping all day, up all night, agitation, wandering, depression and anxiety, apathy is a behavioral symptom. So we can help with the behavioral symptoms. Hallucinations and paranoia can occur. So sometimes it's actually these behavioral symptoms are what's causing the most challenges and problems for the family and loved ones and caregivers. And thankfully, we do have robust treatments that can help kind of calm down the behavioral symptoms, and where science and research needs to do better and help us, and they're working on it, is to get those treatments that can either slow down the disease progression or cure it outright. So we're looking for that, and hopefully we're going to get there. I'm optimistic we will. But for now, we have Aricept, Namenda, Exelon type of cognitive meds, modestly helpful, and treatments for the behavioral changes. There are behavioral changes that come with dementia.
So I think a takeaway of what you said is, look, so from the caregiver's perspective, it is really those behavioral issues that are the most stressful within the family, right? So again, being able to get, not just speaking to necessarily your primary care physician, because while some do focus in an older population, not all do, but having an expert opinion to be able to potentially find a way to mitigate those symptoms might lead to a better relationship within the family, because if anybody's going through this, it's a stress on the entire family. Yeah. I just want to speak on, a couple of where we intersect from the legal side quickly. We started at the beginning, and I said one of the ways that Matt and I work together is that if a person doesn't have capacity, that we will utilize his services, because in New Jersey, in order to assist somebody who no longer has capacity, you must have two physicians, or a physician and a psychologist, assessment that an individual doesn't have the capacity, those executive functions that we were talking about at the beginning. Not that they're choosing to make bad decisions, but the way I put it is they don't have the ability to make good decisions. So one of the ways that Matt and I will work together is because a family requires those. They have to be issued within 30 days of a complaint for guardianship, where somebody is seeking to be able to be put in a legal position to be able to assist somebody, is actually doing an assessment for a person. Now, back in the day, 9 whole months ago, Matt, I know you used to actually go and visit with people and talk to them, but I believe you're providing that virtually right now for people who may need to explore a guardianship type of arrangement.
That's correct. That's actually, currently, that's how we're doing our medical services and our legal services, like for guardianship proceedings. Obviously, we usually need someone there to kind of facilitate and assist with the camera, with the computer, and sometimes there can also be maybe like hard of hearing or just the communication barrier. So sometimes that person might be an intermediary just to repeat or relay the questions on site for the person if they're not totally hearing it clearly through the computer, which can happen.
So from my perspective as an attorney, and a guardianship is a very expensive process once we have to get the court involved. And we usually need it because somebody has experienced a decline, whether it was a slow decline or a sudden decline, and they no longer have that executive functioning, and somebody else needs to be able to assist them, primarily, they're no longer safe to themselves, or they no longer have any capacity to address their financial issues. It's expensive because you hire an attorney, you have to hire 2 doctors. Whatever services Dr. Barnas would provide are not covered by Medicare when it comes to these assessments. They are a private pay service. You have to have then a court-appointed attorney, so there's another attorney, and you have to go to court, which is not the the easiest and most comfortable thing to do, although these days you do it via Zoom essentially. It's not necessarily to get to that point, and if you've listened to these webinars at all, I'm always hitting on the value of having a power of attorney. Okay, so power of attorney is the idea that I, mom, can give someone else the ability to make financial decisions for me, the ability to assist me with things at some point in time in the future. Oftentimes, the powers of attorney say that you're effective right now. At this point in time, you have the ability to act under these roles. But another thing that it might be is we have a springing power of attorney, because sometimes people don't trust their kids, or they want to be independent, or whatever the case may be. They say, you know what, I want to absolutely make sure that I am in control of my finances as long as I can be. But if I can't be anymore, then someone else can take over. So that's another area where we might work together, so that Dr. Barnas would then do an evaluation of somebody to be able to say, do they still have the ability to manage their financial affairs? Maybe yes, maybe no. And if the answer is no, then the power of attorney becomes effective. I say this to you because if you have a loved one who is resistant to the idea of giving you control, by having a springing power of attorney, where somebody with Dr. Barnas's credentials and experience is the one who is saying objectively, you do or do not continue to have the physical ability to be able to make decisions for yourself, and now somebody else takes over. Again, it might be something that you could find as an agreeable compromise, where you're looking to be able to help someone who's maybe very concerned about losing their independence, which Matt, you touched on just as part of getting older, that's sort of a fear that people have. If you can flip to the next slide, please. I think we've answered all the questions that were posted today. If you have any others, our contact information. My email, Dr. Barnas's email, I encourage you to visit his website. There is a frequently asked questions section. It's under, I believe, about, and then you click on it and it's frequently asked questions. It really covers a lot of what Matt talked about here today. So if you are maybe need to share this idea with some of your family members, I encourage you to look at that as a resource. It's really quite excellent. I refer people to it frequently. Also on Porzio Planning, we have a number of resources around, how do you, again, the empowerment side of it. How do we can't control whether or not somebody gets Alzheimer's, but how do we deal with what the impact of that is? We have a number of articles and then the video library from this as well. So with that, we're at the top of the hour. Matt, I just want to say thank you so much for joining us today. My fervent hope is that at least one person who's listening, when they engage with their family members over this holiday season or the next time, that maybe because we've been able to lay out a path of how the medical diagnosis might be able to assist them in the care that they're doing, that they'll be in a position to get started sooner rather than later, and put that plan into place to deal with something that there may be no treatment for, but there certainly can be ways to be able to plan for how the family is going to react to it. So I really appreciate you donating your time to do this today. And to everybody who's watching, this is our December presentation. So I wish you a wonderful holiday, whatever that ends up looking like in 2020. Thank you very much. Have a nice day. Bye-bye.
Bye-bye.